Yes,
Yes.
Professor, we see it.
Okay, thank you. Okay, we're going to continue practicing some questions unless you want to cover any content. Okay, so uh, be free, feel free to introduce any suggestion. Meanwhile, let's see this question. While receiving an infusion of an antineoplastic medication, the client reports a burning sensation in the area surrounding the intravenous insertion site. The nurse observes swelling and redness in the affected area. After stopping the infusion, what should the nurse do next? Hmm. Remember that this next is the same as first. So we have as options using a syringe, aspirate the medication from the IV catheter. B, apply warm moist heat to the area with a pressure dressing. C, flush the IV line with at least 10 milliliters of 0.9 normal saline and remove the IV and immediately notify the client's primary healthcare provider. What do you know about this? Somebody have the knowledge, the answer of this question? Don't be shy. Don't be shy. No problem with committing mistake here. The bad is to commit mistake in the here, no problem. Go ahead.
Remove the IV.
Okay, so this is something that we need to know. The Society of IV Nursing has established that in case of a medication considered a vesicant, so a vesicant, ¿cuándo estaba allí? Ok. ¿Por qué se me pierde? Ok. Vesicants. Those are medications that are administered intravenous, and intravenous are okay because they dilute in the circulating blood. But if accidentally there is a rupture of the vein or the catheter is dislodged, the catheter should be inside the vein. Yes, the catheter should be inside the vein. Yeah, and the medication flowing there. Yes, but if accidentally the catheter gets, dislodged and is outside the vein, is here. So the vein is broken, and now the catheter is here. What means that the catheter is in the interstitial space. Suppose that this is the skin, this is the vein, this is the vein. Yes, this is the vein, and the catheter with the liquid that is considered a vesicant is spilled outside the vein. Make sense? And this is the scenario. So when this is happening, the recommendation is to stop the IV infusion immediately, of course. Why? Because this is substance that is considered a vesicant is a substance able to produce necrosis, death of the cells of the interstitial space and the skin. So the cells of the skin, the epithelium of the skin, the dermis and the epidermis, and all the subcutaneous tissues can die and suffer necrosis as a consequence of this medication. Many medications are considered vesicants, but the most commonly tested in NCLEX is cancer medication, antineoplastic medication, because those are medications intended to kill cells. But also, for example, dopamine, which is used for blood pressure, low blood pressure, no, in certain unresponsive hypotension, or very high concentration, very high osmolar solutions like total parental nutrition solution. Calcium gluconate is considered the own potassiums in high concentration could be considered a vesicant. So there are many substances that are different from the IB fluids. IB fluids are normal saline, half normal saline, D5W, etc. Those are not vesicants. And when the spillage of those liquids occurs because the catheter is dislodged outside the vein, is called infiltration. Infiltration. Yes, when this is IB fluids. The IB fluids are okay, no harm, no risk of necrosis. But when the substance is a vesicant, the term that is used is extravasation. Extravasation. Okay, so you need to know that it's in English. I can assure you that. Okay, so summarizing, catheters can accidentally be dislodged and can be outside the vein. So now the liquid that is intended to be infused intravenous is now spilling in the subcutaneous and the skin and the tissue around the vein. Those liquids can be of two types. Can be the IV fluids, which are not harmful, at least in reasonable amount, are not harmful. So cannot produce necrosis. In those cases, it's called infiltration. And what you need to do is to stop and remove the catheter. That's it. So you are right. Option D would be right if it were normal saline. But the problem is not normal saline, it's antineoplastic medication. When it is antineoplastic medication, it is called extravasation, not infiltration, and this is an issue. So now we have a problem. We have this medication, this very toxic substance spills forming like a lagoon there, no, accumulation of the liquid in the subcutaneous, in the perivenous, okay, tissue, and the tip of the catheter is precisely inside this amount of liquid that is extravascular. So what could be smart, knowing that this liquid is, if left there, is going to produce necrosis of the cells surrounding the liquid? You can insert a syringe. You can insert here a syringe, and you need to try to suck, okay, with this syringe the highest amount possible of this liquid. So now you are sucking through this catheter. So you remove the IV solution, yes, but you left the catheter that is dislodged. You left this catheter. The catheter that is dislodged is left in the subcutaneous, and then with the syringe you are going to suck. You are going to suck. Okay, okay, you are going to suck. I don't know what I did. Okay, what page is this? No, Virgin. No. You are in 9. Okay, sorry. You need to suck this liquid. So what is going to happen now? You suck the highest amount possible. Never is possible to suck all, no, but at least you are going to suck as much blood and liquid as possible of this accumulation that you have here. What you are doing? You are minimizing the extravasation. You are decreasing the amount of aggressive tissues that are liquids that are going to be harming the tissues, and this is the recommendation. So the answer to this question is A. Use a syringe, aspirate the medication from the IV catheter. Are we good? Immediately after that, communicate. Leave the catheter. Don't remove the catheter. You know that is not in vain, but leave the catheter, because sometimes those vesicants have antidotes. For example, dopamine, which is one of the vesicants that are more frequent have extravasation, have an antidote. Okay, has an antidote. and it's called phentolamine. Dopamine. So if some of this dopamine is left there, and the phentolamine is the ¿cómo se llama? Is the antidote. I inject the phentolamine through this catheter, and then I neutralize the undesired effects of the dopamine. It's clear. Did you understand me? Say yes or not.
Yes, Professor. It's
Yes.
clear.
Okay, so I promise you that this question is in the question bank of Nclex and appears with certain frequency. Okay, so summarizing, if it is just IV fluid, you stop and you remove the catheter, elevate the extremity, and that's it. But if it is chemo, which is a vesicant, need to be done something more. You independently know that by protocol, you need to suck the highest amount possible of the liquid with a syringe, leave the catheter there in the site of the extravasation, and call report to the doctor, because sometimes those liquids can have antidote that can be instilled through the same catheter. That's it. This is what you can learn of this question.
Professor,
The, yes, yes,
in
yes.
the practical life, uh, how many mLs?
No,
How
niña, as much as you can.
okay.
If whatever you can retrieve, remember that the catheter is not in vain. There is a limited amount of liquid extravasated, and then you in real life you don't expect to be retrieving more than 1 milliliter or something like this, one and a half, two, because it's a small amount. But understand, if you have a venom in your body, and you can retrieve, you can remove this venom, is a gain, whatever amount you can remove. Okay.
Thank you.
My pleasure. The nurse is preparing a client with suspected lung cancer for thoracentesis. You know what is that? No? It is a puncture of the pleural space with a needle and a catheter with the intention of removing liquid. Excuse me. Sorry. The client just had a chest X-ray that confirmed the presence of a pleural effusion. The nurse provides education prior to the procedure, which is statement by the client indicates further teaching is necessary. So obviously, what is the question about? The client said something that is wrong and requires clarification, needs to be retaught. I will have to try to not cough, talk, or move around during the procedure. The procedure is going to last 20, even 30 minutes. So it's okay to avoid coughing as much as possible. Talking is not necessary unless, it's an emergency, and less moving. So they can do that. I will be sedated for this procedure, and I will need someone to drive me home. When there is sedation involved in the procedure, you need to be sure that somebody is driving the client home, because they cannot drive. It is a common um, safety item in procedures that require sedation. My question is, do you think that a thoracentesis requires sedation? Yes or not?
No.
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 The answer is no, because the client must keep the upright position. The client can be as upright as possible. Okay, because precisely what is the rationale of having this position? Because the liquid that is free in the pleural space should be moved by the gravity force to the bottom. The doctor will introduce, okay, the needle in the bottom of the pleural space, but the doctor needs all the liquid to be accumulated here. So the gravity force is accumulating the liquid here. This is the rationale for which the client need to be in this upright position. That's why, and this arm need to be away from the area in which the doctor is going to be working. That's why it's good to find, an upper bed table or something solid that allow the patient to be resting comfortably. You put the pillow here, and that's the ideal position. This can be a chair, or can be the bed border. Uh, So it is a bedside procedure if the client is hospitalized, or an ambulatory procedure if the client is doing that in the doctor's office. But it is after the insertion of the needle with yo voy a poner esto más grande, pero yo no lo veo. With local anesthesia, okay? Local anesthesia, the doctor is going to be little by little, slowly removing with a syringe, okay, certain amount of liquid. Generally, no more than 500 milliliters, it can be more. Okay, so and now we know that the answer is B, but let's see the other option. So the A was okay. The patient can be breathing, of course, half an hour, okay, but the patient should not be moving, should not be talking unnecessarily.
Professor,
Yes, yes.
let me ask you something if I can. And
Sure.
I'm sorry to interrupt you.
No,
I
no.
want to know what is the exactly amount of mLs that the patient can be draining
Okay, okay.
after do the
The
procedure. Yeah.
ideal is not to drain more than 500 milliliters, unless there is a tension of pleural effusion. If there is need of removing more than 500 milliliters, because it's
Mm-hmm.
calculated by the X-ray, it's better for the doctor. This is doctor's decision, not nursing decision. But it is better for the doctor to introduce a chest tube. The chest tube allows to drain little by little. The amount is not important, it's the speed of the removal of the liquid. If the liquid is removed too fast, then the lung can develop a unilateral pulmonary edema, and the clients can enter in respiratory distress. So that's why should not be removed more than 500 milliliters is the general the protocol. Okay. If it
But
there are
after, yeah,
if
but
there
after I see some questions after the patient receives the procedure, the nurse can be worried if see more than 150, for example, in the drainage bag, or
no, it is
it's still
another. This is another
it's when the
100 per
patient has,
hour,
yeah,
100 milliliters per hour in the
okay,
chest tube drainage, in
in
the
the
closed
chest tube theater,
in
okay,
the chest tube, more
okay,
than 100. But doctors can, during a thoracentesis, remove no more than 500 milliliters. Okay, during the thoracentesis. Understand that the thoracentesis is going to remove liquid
yeah, but
in,
not necessarily the patient is going to have a chest tube
no,
after, of
no,
course,
no,
okay,
in half an hour or more or less. Yes. So it is. There are some cases like the tumoral pleural effusion in which the doctor need to remove as much as 100 milliliters to improve the mechanic of the respiration. In the case of the questions, of the monitorization of the drainage through a chest tube, not thoracentesis, chest tube, if you observe an, a flow of more than 100 milliliters per hour of liquid per hour in the collection chamber, you should report that. You need to report that. So it's the same as a becoming concern. Okay, you need to report that, absolutely. And of course, if you observe that it is bright red, of course, it is a priority to report because the patient is bleeding. Okay, so those are the limit. But the thoracentesis are different. Okay, situations that are done by the provider, not by the nurse. And the maximum allowed in tumoral, okay, pleural effusion for 100 milliliter. Um, After the procedure is over, I will have a chest X-ray done to make sure everything is okay. It is correct. After the
yes.
procedure ends, okay, a new X-ray can be done to evaluate the amount of liquid that is left and to rule out pneumothorax. This procedure can be painful. It is true. It's painful Not because the needle is practically non-painful. Is that after, you have two layers of pleural, and between the two layers you have liquid, yes. But why you have liquid? Because the pleural membranes are inflamed. After you remove the liquid, now the two pleural membranes are not going to be separated by liquids, are going to be touching each other, and they are inflamed. So for that reason, the breathing will be painful. Yes. So after the procedure, is expected that the clients will experience pain to breathe that was not present before when the liquid was present. The liquid was separating the pleural membranes that are the one that have pain receptors. For that reason, the patient maybe is having problem to breathe, but is not experiencing pain. After they remove the liquid, okay, maybe the client is breathing better, but now is having pain. So anticipate that the doctor must prescribe pain medication. So is expected pain after the thoracentesis. So yes, the answer of this question is easy. Okay, is the client doesn't need to be sedated because the clients need to collaborate, and if the clients need to collaborate, cannot be sedated. This is the rationale for this. The client was brought to the hospital after a fall while climbing a mountain. The client is admitted to the intensive care unit with the following assessment finding. Okay, 3-inch laceration to the top of the head, bruises to the face, right humerus fracture, and multiple bruises on torso and legs. Pulse 89, respiration 20, blood pressure 128/82. So it's okay. Maybe in the upper limit of respiration. I assume that it should be in pain. No? Which set of vital signs assessed 1 hour after admission requires immediate intervention by the nurse. So notice that it is a question of trend, so evolution, okay? Trend of evolution. So what of these vital signs 1 hour later make you suspect that something bad is happening? So now you have the first pulse or a mild tachycardia. Respiration improves and blood pressure increases a little the systolic, but is still stable. It suggests that is activation of the sympathetic nervous system. Could be pain. It's not hypotension because the blood pressure by the contrast increase. Could be pain. Fever, I don't think it's going to be so soon. Maybe pain. Okay. Pulse 76. So a drop of the heart rate from 89 to 76. Okay. Respiration 22 increases. And blood pressure is more or less the same. Okay. Little higher. Pulse 96 increases the pulse. Respiration 20. Blood pressure 112/68. Pulse 56, an important, significant drop of the heart rate, no? That is not expected in a client polytraumatized. What we expect in a client polytraumatized pain. And
Tachycardia.
yes, I expect pain and the pain tachycardia. And of course bleeding, but it looks that is no bleeding. All the blood pressure suggests there is no bleeding, at least
Yeah.
internally.
Yeah.
And the respiration is dropping from 20 to 14. And there is an increment of systolic, being the diastolic the same.
It's D. I think it's D. The most
And
concern, I
what
think
kind what kind of situation are you suspecting?
it's maybe the patient has autonomic dysreflexia or maybe a neurogenic shock. I don't know.
Okay,
You say what?
Sound familiar?
Oh yeah, of course. Yeah, Cushing triad.
Pushing
Okay,
Hypertension,
remember that the
schizophrenia. Yeah,
client on purpose are describing a injury on the head. Yeah. And injuries on the head
yeah.
can produce brain edema, yes, or bleeding, brain edema or intracranial bleeding. Yeah. And now what we are noting and calls our attention is the bradycardia. So this is the clue of this question. And then we notice that is a depression,
Brademia.
the respiration,
Brademia
increased
too.
systolic and
Yeah.
persistent the diastolic descent. It suggests Cushing triad. So yes, it's D, but suspecting Cushing triad. So yes, it's D. Why I disagree with autonomic dysreflexia. I want to discuss this with you because has been tested very frequently. Okay, in autonomic dysreflexia, we need to have a spinal cord injury described in the scenario above T6. So could be T5, T4, T3, T2, T1, cervical, etc. Yes. And you need to know that it happens days, if not weeks, after the initial injury. Because immediately after the spinal cord injury, you have a period called spinal shock. In the spinal shock, you have hypotension, okay? And is of course you are going to have paralysis, but it's a flaccid paralysis. So there is a decrease muscle tone and absence of reflexes below the level of the injury. In this period that is going to last, as I said, 1 week, 2 weeks, even 3 weeks of a spinal shock, you don't expect the autonomic dysreflexia. But after these 2-3 weeks passed, yes, after the initial spinal shock, now we observe that the vital signs stabilizes. We observe that the paralysis continue, but now the paralysis becomes the opposite, hypertonic spastic paralysis. Spastic paralysis. And the deep tendon reflexes return and are increased, are hyperreactive. Is in this stage when the spinal shock after 1 to 3 weeks have passed, when the autonomic dysreflexia can appear. In the previous scenario, they are describing the in 1 hour after injury. If this client were having a spinal cord injury, should be still in the spinal shock period in which you don't see autonomic dysreflexia. Okay, the autonomic dysreflexia is a complication that appears later, weeks later, when the spinal shocks recovers, and now the client enters in the opposite scenario, and they need to tell you that there is a spinal cord injury about this 6. So next time when you see autonomic dysreflexia, think that it's not immediately after the spinal cord injury, is a week after, and the rest of the life, because the client can have this risk the rest of his of her life. And ¿cómo se llama? Sí, remember that it is not immediate. Okay, so now and remember me for test purposes. Remember here I'm here trying to help you to pass the English. They always mention the level of the spinal cord injury and need to be T6 or above. And when they mention that, you say, oh, this is a question about autonomic dysreflexia. It's important that I explain you that because, for example, one of the questions that you can have of new generation is a clinical scenario like this. And then they say these findings can be related with ICP, spinal shock, or autonomic dysreflexia. And then they say increased bradycardia, or can be in increased intracranial pressure and can be in autonomic dysreflexia. You know, and they give you a list of findings, and you need to be marking in this new generation question in which of these three diseases you expect the findings. Okay, so it's good to discuss. And don't forget, please, don't forget that when somebody has the bad luck of having a spinal cord injury at any level, first is going to be through a 1 to 3 weeks period of spinal shock, where the blood pressure is going to be very low and is going to need life support. I mean, IV fluids to fill the vasodilated, because the reason of the spinal shock is that the arteries suffer an intense vasodilation. Should be like this, and then because the autonomic dysfunction, uh, there is a vasodilation. It's called distributive shock because the blood vessel becomes too wide, and then the pressure of the blood inside decreases. So that's why I need to be administered fluids, IV fluid, to fill this increased capacitance of the blood vessels, and vasopressors, okay, like the dopamine that we mentioned, to produce vasoconstriction, to produce vasoconstriction. This is the spinal shock. You don't expect hypertension in this period. No increased blood pressure like in this. And remember, because they asked that the client is paralyzed. Yes, it's paralyzed. Okay. But the paralysis flaccid is without muscle tone. Is like a like a rag doll, like a without any muscle tone. And the reflexes, the deep tendon reflexes are zero. Deep reflexes are zero. you know. Then 1 to 3 weeks later, the paralysis persists, but now is spastic. Now the patient becomes stiff, paralyzed, but stiff, spastic. Okay, and the deep tendon reflexes return and return exaggerated to high. This is frequently tested. Okay, frequently tested. If you know these two, and then when there is this spastic paralysis, etc., is when you can have the autonomic dysreflexia. There is a urinary retention, blah, 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 blah. Okay, so I saw this topic in English, so I wanted to discuss that. Okay, I saw this question even recently. This question was very recent, commented to me. Okay, so this is a good question. Huh? It's a good question. So remember that here the trick is that remember that the trauma in head and neck and head are the priority. Okay, are the priority. Okay, in this case, the nurse is caring for a terminally ill hospice client. The client is currently reporting pain all over. Is it worse than ever? The nurse assesses the client and records the following data: blood pressure 104/60, apical pulse 74, respiration 8, and shallow. Which intervention should the nurse implement? Notify the healthcare provider of the client's signs. Call the doctor. Pass the book. Turn and reposition the patient for comfort. Use non-pharmacological interventions for pains like non-pharmacological massage, digital pressure, guided imagery, aromatherapy, music therapy, humor therapy. Use non-pharmacological interventions for pains and reassess in 15 minutes. Administer the morphine order for pain. What you would answer in your NCLEX if you have this question?
D, administer the morphine. He's already in
Because
hospice.
But
Every,
but
uh-huh.
she had a respiration.
And can
I don't
die,
think
no?
so.
And can die.
Yeah, of course.
Yeah,
Can
Yeah,
die,
you
no?
can kill the patient. Yeah.
it's a
Can
terminal
die.
hospice,
Okay,
but
well, you need to accept that one day we are going to die. And if we are in this process, the being a terminal condition, yeah, in a terminal condition that we are going to die, it is a fact we cannot we cannot avoid. Okay, and we are declared in hospice. The purpose is to die without pain, without shortness of breath, without discomfort. You understand? So in this scenario, you need to learn that the morphine is ordered to be administered independently of the respiratory rate, which is something that is going to happen in the process of dying. And the important here is that the only thing that is going to remove a pain all over worse than ever in a patient that is dying in hospice, the only thing that could help in this scenario is the morphine order for pain. So yes, it's something that you need to learn. That's why on purpose, why? Because you don't have experience with this.
ah,
This is a client that is not in hospice. It's a client that is not terminal. A client that, okay, we need to find alternative to the use of opioids, but not in case of hospice. Are we good? Yes.
Yeah. So it's
Okay.
D.
Okay. So it's difficult to accept, but the answer of this question is D as in diamond. Administer the morphine. Okay, we know that the client is going to die. This process of periods of apnea, respiration of chain stroke, etc., is part of the process of dying. What is important is that the person dies without unnecessary suffering. A client is involuntarily committed to a psychiatric facility. Guys, maybe you don't master this term. This is what you used to call Baker Act. I noticed that my students call this Baker Act. Baker Act refers only to this situation to Florida, and the NCLEX is not a state test, it's a federal, it's a national test. So they cannot use Baker Act to explain you the concept, the term, the legal term that applies all over the country is involuntary commitment. Involuntary commitment. Okay, commitment. Okay, this is the term of when a person is a risk for himself or to others. When a person is suicidal, for example, when a person is extremely self-neglecting, like terminal schizophrenia, a patient with anorexia nervosa, etc. There are clients that are killing themselves, and extremely not killing, factually as a suicide, but are neglecting themselves so much that it's like killing themselves, or when they are a risk for others, when they are violent, homicidal, etc. So a client is involuntarily committed to a psychiatric facility. During an assessment, the client reveals to the nurse a plan to harm a specific family member. So it looks like this client is homicidal and is reveals to the nurse a specific plan targeting a specific person. and you are in knowledge of this information because the client was confident with you. Which of the following actions is a priority? So take care. This word priority means that maybe there are more than one actions that are okay or correct, but not necessarily is the priority. Let's see. Ensure the provider and the family member is notified of the threat. Encourage the client to discuss the plan to harm the family member with the healthcare provider. Incorporate the client's plan to harm a family member into the nursing care plan. No action is necessary because the client statement is protected as a confidential information. The patient confident with you, confident with you. What do you think is
It's
the best
A,
answer?
Professor. A.
No,
Letter A, Professor.
letter A. You have the duty to report this. You know that confidentiality has exceptions. And for example, the diseases that are of mandatory report need to be reported even against the will or the desire of the client. For example, this situation, okay, when there is a plan of harming a person, you need to obligation to report that. You know if there is you suspect abuse of children or elders, and they give you this information as a confidential information, you need to report that. You cannot compromise with the client that this information is going to be kept confidential because it is of mandatory report. What else? Okay. Um, mm, Suicidal attempt. Okay, suicidal ideations is around the mandatory report. When you see a nurse or a physician consuming substances or impaired to take care of clients is a mandatory report. So be aware of all those situations in which confidentiality is surpassed by the mandatory report. And this is one of the cases. You know that there is the duty of reporting that, but not only to the authority, not only to the physician. You need to verify that the potential victim, is informed. Okay, is something that has precedent. It's called the Tarasov law. Okay, so the family member that has been uh, threatened by the client need to be informed, and you need to be sure that it's informed. Okay, so good, you are good in this, no problem with this. A client frequently admitted to the locked psychiatric unit repeatedly compliments and then invites one of the nurses to go out on a date. The nurse should take which of these approaches. Okay, so the client is the nurse patient, no? And the client is insinuating to the nurse. Okay, so what you should do, ask to not be assigned to this client or request to work on another unit. Do you think that it is a, a justification to request to be eximit, okay, of this client?
No, Professor.
No, this is not enough reason. This is not enough reason. So there are situations in which you could request, okay, you could request a change of assignment, but this is not a justification. Okay, so we rule out this. No. Discuss the boundaries of a therapeutic relation with the client. So talk to the client. Talk to the client and explain what is a nurse-client therapeutic relationship and what are the limits. Could be tell the client that such behavior is inappropriate and unethical. It's very,
No,
ve-
because
very
you
stern,
are
no?
getting,
Very stern, no? Very is the client is going to feel very bad, no? In reality, the client is not committing any crime. The client only, likes you, but the client has not been trained in the ethical principles of a therapeutic client-nurse relationship. So when you say that to the client is going to feel like if we're committing a crime. This is inappropriate and unethical. So it's going to feel contrary. What I did, okay? I just asked her to go out when I get out of the hospital. So it is like very, very stern, very harsh. Doesn't look therapeutic. Inform the client that the hospital policy prohibits staff to decline. So pass the buck to the hospital. So I want to go out with you, but the hospital doesn't allow me. It is like, double standard. So the best answer obviously is B. Okay, so those are questions that if you think the question, okay, it are easy. A client is admitted to a voluntary hospital mental health unit. Notice this is voluntary. Okay, with a diagnosis of suicidal ideation, but he wanted or she wanted, I don't know if it's he or she, to be hospitalized. Okay, the client has been on the unit for 2 days and now states, I demand to be released now. The appropriate response from the nurse should be which of these statements? Let's see. You have a right to sign out as soon as we get the healthcare provider discharge order. So they are given the right of living, but they are conditioning the discharge, the living, to the approval of the healthcare provider. You need to understand it. Remember that the best strategy is to understand what you're reading. The second option say you cannot be released because you are still at the risk of being suicidal. Let's discuss your decision to leave, and then we can prepare you for discharge. You can be released only if you sign a non-suicide contract. Have you heard about this non-suicide contract? It is tested, okay? I don't know if you remember that from mental health. Is a custom, is usual that psychiatric doctors ask clients that are suicidal to sign a formality, a non-harm contract. Okay, so it's like something where you say, okay, I promise that if I start thinking again in killing myself, I will ask for help. More or less is what says this stuff. Of course, refusal of signing this non-harm contract increases the risk, the potential of suicide. No? So this is this contract. Okay, so if you didn't know that, by the way, has been in English. Okay, but here say you can be released only if you sign a non-suicide contract before you leave. So all are very interesting. Okay, so is this client legally? This client can leave the hospital? Yes or not?
Yes.
Yes.
Yes,
I think it's
because
the same, Professor.
it's a voluntary admission. If it were if this were an involuntary commitment, no, cannot leave the hospital. So legally, you need to discriminate the involuntary commitment, or you call Baker Act, of a scenario like this that a client was admitted voluntarily to the hospital. So the client can leave whenever the client wants. So there is not a need of doctor's order. They can live against medical advice. So this is incorrect. You cannot condition the, the, the discharge to the doctor order, because then it could be a case of false imprisonment. Okay, you cannot deny the right to lift. So it is more, so definitively no. So now we're left with C and D. And which one do you think is the best option there?
C.
Option C.
Yes, obviously C, no, because C opens the possibility that the client talks to you, okay, open-ended, okay, scenario to speak up about the plans of the clients, okay. You accept that the clients can live, okay, and you don't deny the discharge. Of course, in this process of discussing the decision of living, you are going to make an assessment, you are going to make a reassessment and evaluation of the risk of suicide, if there is a plan, etc., etc. And remember that clients that live against medical advice, okay, can receive doctor's orders. So they can receive, if the doctor is informed, the doctor can provide treatment to be continued at home, okay? In those cases, so no problem. So there is a lot of thought that can be prepared for the discharge. So it is the best option. Okay, there is no conditioning, there is no a legal limitation of any kind for leaving the hospital. If you introduce any limit, it is even a possibility of a felony called a false imprisonment. We cannot do that. Okay, that's it. A 3-year-old child is brought to the pediatric clinic after experiencing the sudden onset of irritability, thick, muffled voice, cracking on inspiration, and skin that's hot to the touch. So it's a kid that is having fever and is having a sound that during the inspiration, probably is a stridor, and call the attention that the voice is muffled. The child sits leaning forward. So it's sitting and leaning forward, tongue protruding, drooling, and has supraesternal retractions. When they describe that, guys, you have only one options, okay? Only one option, that it
Epiglottitis.
is an epiglottitis.
Pilotitis.
Okay, it is a child that is sitting, okay, is sitting, is sitting, and is drooling, is sitting in the tripod position, is drooling, the tongue protruding, and with a stridor, etc., is an epiglottitis. So notice that in these questions can do like in Nclex, they don't say the word epiglottitis. With the symptoms and signs that they give you, you need to diagnose epiglottitis. And then the question is what you do first. Remember that those first are make very difficult, okay, the question. Notify the healthcare provider of the child's status, collect a sputum specimen, assess the child's throat, prepare the child for x-rays of upper airway. What do you think?
A.
A, it is an absolute emergency, and you need to activate the rapid response team, the doctor that can arrive as soon as possible. This is the priority. You need to notify immediately as an emergency. Is the A of ABCs. Is the A of ABCs is one of the absolute emergencies. In any moment, the obstruction can be controlled, and then you can have a child that can be crashing. Remember that you should not force the client to lay down. You need to respect this sitting and leaning forward position. Remember that you need to keep the child NPO, and you should not introduce anything inside the mouth. No tongue depressor, no thermometer, no swab of the throat for culture, nothing. Oxygen can be initiated, okay, and be ready for a tracheostomy in endotracheal intubation and eventual tracheostomy. That's it. Very good. So, are good. A healthcare provider asks the nurse to assist with the obtaining consent for surgery. The client is an adult male who is deaf, but can read and understand sign language. So, doctor is present, nurse is present, client is present, but the client is deaf, but can, read a sign language. While the healthcare provider explains the procedure and risk to the client and a family member. So there is another person there, a family member. The family member was texting the phone the information to the client with their telephones. Funny, no? What is the nurse's responsibility in this situation? Remind the doctor to ask only one question at a time. Request the doctor allow extra time to write the information to the family member. Stand next to the client and verify the information texted is accurate. And D, interrupt the doctor and ask about obtaining interpreter services for the client. What do you think?
D.
Everybody agree?
I don't know. I'm not pretty sure, but I am between D and D.
B and D, okay. Request, okay. So remember, the role, remember that your English is going to be a perfect scenario. And in reality, most of the hospital have those resources. You have interpreters, not only interpreter for foreign languages, also interpret for deaf people. Okay? So the role of as an advocate of nurse advocate is to request an interpreter, because what we are having here first, do we have stated in the question that the family member is authorized to know the information that the doctor is delivering to the client? No. We always need to be very careful with this. Sometimes we don't want a family member knowing what is happening with us, but we are like, afraid of denying the presence of the family member because can get upset. First, there is a violation of confidentiality there. Second, the other family member is not a medical professional interpreter. The interpreters must be professionals trained in medical interpretation. And a CNA that speaks the language, or another family member that speaks the language, or a bilingual can translate, is not good. So the same situation that you see, that you have a client that speaks a foreign language different from yours, and that is a CNA that is bilingual, speaks this language, you cannot use the CNA. Or there is a family member that is bilingual, you cannot use a family member for the translation, at least in the scenario of English. Why? Because unless it's stated in the question that the client is approving these family members and whoever to know about his or her intimacies, this is a violation of confidentiality, and this is something that is sacred. It's something that needs to be respected. So for two reasons, because the quality of the interpretation by the family member, because it's not a medical interpreter, and because confidentiality is violated, the use of a family member in any motion, any mode, is inadequate. The only person who should be doing the interpretation or translation or whatever you call this is a professional interpreter. So this is the same as this other question that we have. The answer is D as in David is the only option possible. Do we agree?
Yes.
Yes.
Okay. It's good to reinforce those legal concepts before going to English, because I can assure you that English give a lot of importance to this legal aspect of the practice of nursing. A client is being discharged with a prescription of chlorpromazine. Entonces, you are in the test and you are, oh my goodness. Me suena, pero no me llega. Okay, chlorpromazine. Okay. Before the client leaves for home, which finding should the nurse teach the client to report right away? Sore throat and fever, abdominal pain and nausea, lethargy and drooling, change in libido and breast enlargement. So, what could be the situations in English? Situation number one, you know what is chlorpromazine. It's a typical antipsychotic, okay, of the phenothiazide family, okay, is the promazine, okay, group, okay, phenothiazines, okay, the trifluoroperazine, chlorpromazine, etc., okay. They are all the antipsychotic medications that are also used for nausea, for nausea and vomits, can be used for hiccups, okay, etc. Has potent anticholinergic, anticholinergic activity. So you expect dry mouth. So it is ruled out. Is sedating, but drooling is not. The medication is used for nausea, and is not a reason for causing pain. So is not a reason. So now, knowing the medication, okay, knowing the medication, you can this medication works inhibiting the dopamine, but is not modifying neither the level of hormones like testosterone, okay, or the secretion of prolactin. The one that produces this effect is the haloperidol. Haloperidol is another typical or old antipsychotic medication, but it's another family. Is the butyrofenone, okay? Haloperidol. The haloperidol increases the level of prolactin. Prolactin is a hormone that we have, men and women, that in women stimulates the production of milk after birth, no? But are present in both genders, because when you increase prolactin, breasts enlarge and become, tender, and the libido decreases. Prolactin inhibits the libido. Usually, postpartum women have not too much libido. It's because it's are breastfeeding. So it is in relation with haloperidol. So the answer is that. Okay, now suppose the other scenario. The answer is A. Suppose the other scenario. You don't have the least idea of what is chlorpromazine. Which of these conditions can kill the client? Okay, bone,
Agranulocytosis, right?
exactly, bone marrow depression,
Yes.
agranulocytosis. This medication can also produce bone marrow depression, yes,
Yeah.
and need to be supervised. The other that proves that is the clozapine, which is a atypical antipsychotic, also can produce that. Okay, so for strategies, nobody's going to die. Okay, report right away, 3 a.m. Doctor, I'm so sorry calling you at 3 a.m. But I have nausea, I'm drooling, and I'm sleepy, or I don't have libido. Sorry for calling you, okay, at 3 a.m. because I don't have libido. But sore throat and fever is the symptom that characterizes the agranulocytosis because bone marrow depression. And it could be a priority, okay, an urgency because it is associated with septicemia. So it can produce sepsis, yes, because you don't have white blood cells. So a strategy. Okay, sometimes you need to survive. Okay, sometimes you need to survive. Sometimes you don't need to know everything, especially in pharmacology. It's impossible that you learn all those medications. It's impossible. Not even good memory guys and that the nerds. That's why it's so important that you always carry your drug guide and you continue your drug guide. Now it's electronic. You can keep that in your phones when you graduate, start practicing. Don't expect that your memory being dependable enough as to memorize everything about medication. A much safer nurse is a nurse that is consulting the drug guide before deciding, before giving the medication and taking decision. Okay, so that's why you'll see and you remember me that pharmacology as a medication is not the most common question in NCLEX, because people that write NCLEX are very smart people, very knowledgeable people, and they know but and I just told you that it's impossible to know this. But suppose that you have this scenario. What the strategy will report right away, 3 a.m. This has to report right away. 3 a.m. You call 3 a.m. and the doctor, I'm so sorry I wake you up. Okay? And the patient has nausea. Okay, the patient is drooling, he's drooling, and he's sleepy. The patient doesn't have libido. Okay, and the breasts are tender. Please, but sore throat and fever. Maybe some of you don't remember that the earliest manifestation of agranulocytosis is sore throat and fever. Remember that there is agranulocytosis. There is a very low count of neutrophils, and for that reason, the body becomes infected with its own normal flora. And the part of the body that has the highest concentration of flora is the mouth and the throat. The mouth and the throat have a zoo of bacteria, aerobic, anaerobics, any kind of bacteria, and that's why it's the first part of the body that becomes infected and inflamed when there are no defenses. That's why the sore throat and fever should, in a client taking a medication, should make you automatically suspect infection. So I just wanted to share with you that expect in your NCLEX questions about topics that you don't remember or you never heard about. Expect that. And don't think that because you have one or several questions like this that you don't have any idea, you are going to that means that you are going to fail your NCLEX. You need to continue fighting questions after question, okay? Because you don't need to get 100 or a 90 or an 80 to pass the NCLEX, okay? So you can commit mistake and still, if you demonstrate that you are a safe nurse, you can pass the anchors. This is a mental attitude that maybe you don't believe that, but I am convinced that helps to pass the anchors. So here is a strategy for some of you, okay? That you see that and then you freak out. Oh, chlorpromazine, pharmacology, I hate pharmacology. I don't remember. Sounds, me suena, pero no me llega. It sounds familiar, but I don't remember exactly what is this. It is, oh my goodness, I don't know what is this. And then you start freaking out. The anxiety is going to, you know, to defeat you, and don't do that. Try to find a way of answering the question. Okay, relax. You will have in your anchors questions that you don't know or you don't remember, and you still can pass the anchors. And in this case, just using strategies. Okay, supposing that you don't know what is chlorpromazine, you can reach the answer. Good. When should a nurse initiate this high? This is the question that you don't know this, you never went to the fundamental class. When should a nurse initiate discharge planning for a client? Read the answers because you should answer that
Upon admission. Upon
Sí.
admission.
upon admission, upon admission, you know? It's a classical question in nursing. Can this question be in English? Yes, absolutely yes. In English, you have some questions that are very basic and some questions that are very intellectual, very complicated. But you are very, straightforward questions that sometimes you say, oh my goodness, you can become paranoid. And you say, no, there should be something hidden here. It should be a trap here. Not trap, guys. Don't become paranoid. It's just exploring basic knowledge. They explore basic knowledge, but they also explore advanced knowledge and applications and deductions and analysis, etc. So, but sometimes they just explore if you can regurgitate a knowledge that is well established in any nursing career. The nurse is assessing a client who has paraplegia, okay? Paralysis of the lower part of the body. What finding would indicate the probable presence of fecal impaction, presence of blood in stools, continuous rumbling flatulence, absence of bowel movement, oozing. Oozing is a word that means continuous leak. Continuously, the client is leaking liquid feces, liquid stools. So this is what means oozing. Oozing is a continued leak in a small amount, but it's a continuous leak. Could be oozing blood in some wounds. Is frequently this word used in DIC, for people like me that English is not the first language, and many of us in MRU have the same situation like me, we need to also, ¿cómo se llama? Reinforce our vocabulary because can help to pass the English a lot. So in disseminating intravascular coagulation, the client start oozing blood in the venipuncture site. Those are critically ill clients by other conditions that get complicated with a coagulopathy. They don't coagulate, yes? And then wherever the nurse gets a vein, you see a little trickle or leak of blood in all the site of venipuncture, but also in the gums, in the natural orifices of the body, etc. And they use this word a lot. I have by experience that some students when see this word don't understand what it means and they could have problem. So oozing means continuously leaking or allowing the expulsion of a small amount of liquid poo, but continuous, okay? So what is the answer?
D.
D.
Everybody agree that is D? Isn't this diarrhea?
No, it's not diarrhea. It's
No.
Okay, ahí no lo pude agarrar. Okay, very good. Yes, the answer is D as in David. The phenomenon in this is that in the rectum, the client has a mass of feces, like a stone of feces there. This stone feces is going to produce irritation in the walls of the rectum. This irritation produces fluid. Okay, so there is a fluid continuously leak, a mucus and fluid is leak, and this fluid dissolved part a part of the feces that are in the stone. So you are going to see that the client has this stone, this big rock of feces in the rectum, which is the fecal impaction, but then you are going to be noticing that there is a continuous leak of liquid um, liquid with mucus, and particle of the feces is very stinky, and continuously the client is leaking that. It is the presentation of fecal impaction. Okay, a digital rectal examination allows to confirm the diagnosis, and of course the client will require enemas, a digital disimpaction, etc. It is a classical question in nursing. It's a classical question in English. The nurse is assessing a client with myasthenia gravis who has a dose of pyridostigmine ordered at 7 a.m. Prior to giving the medication, the nurse observed and note diplopia, dysphagia, tolerating only nectar-thick liquids and weak cough. The client has ordered breakfast for 8 a.m. Which of the following actions should the nurse take first? Give the client hydrophonium chloride 10 Ceylon. Administer the pyridostigmine as soon as possible. Hold the medication and notify the healthcare provider. Assess for lower extremity weakness. What you would answer in this scenario?
B.
C.
Be as,
Yeah.
be as in boy.
Yes, and boy.
Yes,
Mhm.
boy. Yeah.
How is given the pyridostigmine? In tablets or injections? How is given? No idea. Is oral or parenteral? No idea.
I have no idea, Professor.
Okay, it's oral. It's tablet. Our tablet. Okay, our tablet.
That is
Okay,
to strengthen the muscles so the patient can eat, right?
yes. The only that is parenteral is the hydrophonium. Okay, this is parenteral. This is injected, but the pyridostigmine and neostigmine is oral. So uh, So you need to recognize that the situation is concerning because the client has dysphagia and the pyridostigmine is given orally. Yeah.
That can be tolerable to glucose, so you can dissolve like an emulsion or something.
Yeah, but it is not given in the options. Okay, to crush the medication. So
So
you
it's
should
safe. I don't
you
know.
should you should be very careful with this question. Okay. So you should be, it's true. The classical answer is give the pyridostigmine before meals. So when the breakfast arrives, the client is strong and can consume the breakfast. The classical answer. But you need to be very careful. Okay. That is the client able to tolerate the oral pyridostigmine without choking? Can you harm the client giving the medication orally? Is this client presenting a myasthenic crisis? Okay. Uh, is logic to consider that the client could aspirate when giving the medication, and you should hold the medication and notify the healthcare provider. So don't be so fast to answer this question. Think twice in your answer because, okay, it's between B and C, but you need to weigh the two options. You need to weigh the two options. They are describing a severe dysphagia, severe dysphagia. And the patient is apparently, presenting a exacerbation of the myasthenia, right? So like a myasthenic crisis. You should ask yourself, is it safe to give an oral medication to a client in this condition? Or this client, due to the symptoms, should be evaluated by the physician because maybe the client is having a myasthenic crisis and requires a more acute intervention than just giving the tablet of the pyridostigmine. So it's a suggestion that I give you in your test. Okay, so you need to be very careful that the first is to avoid producing harm. Giving an oral medication to a client that has dysphagia is a risk for aspiration, and being myasthenia gravis a chronic disease, but with the potential of developing myasthenic crisis that requires ICU management, immune suppressors, assisted ventilation, etc., is important. So next time when you have a similar question, I like you to be, more to go slower, and consider the pros and cons of these two options. What is the advantage of giving pyridostigmine as soon as possible? Well, that maybe the pyridostigmine improve the clients and the client is able to have the breakfast. What is the consequence of giving the pyridostigmine oral? And a client that is having important dysphagia and weak cough and diplopia and looks like an exacerbation of myasthenia. Well, that we are first placing the client at risk of aspiration while giving the medication, and we are ignoring that the client is having a exacerbation of flares up or deterioration of his or her condition. What is the advantage of withholding the medication and notifying the healthcare provider? Well, the advantage that we avoid aspiration and we communicate the healthcare provider the patient is deteriorating. The patient has, an intense symptom of weakness. What is the disadvantage? Well, the clients cannot have breakfast because it's not having the medication is going to stay very weak to have that. So this is the way that you need to deal with this question. If you are in Nclex, remember that the main purpose of Nclex is to be sure if you are safe. More than if you are knowledgeable, the main purpose is if you are safe. If there is a risk of aspiration, and there is also a risk in not detecting and reporting a change of condition of the client, deterioration of the client, uh, you should guide your decision based on that. If I were in my English, I were answering C as in cat, better than B as in boy, based on the fact that there is a risk of aspiration while I give the oral pyridostigmine, and because they describe a severe presentation of myasthenia that could be representing a myasthenic crisis. Those are the questions that are a little more difficult than the previous one, in which we need to stop and think a little. And we need to take care because they can use a distractor. A good question is a question that has good distractors. but have enough information as to allow you to consider other options. Okay, so a good distractor is an stereotype answer, the answer that you have been answering always in all the tests, the answer that maybe is staying in your memory, but not necessarily what was the correct answer in previous question in the new scenario is a good answer. And what we can learn here is that for the treatment of myasthenia gravis, the medication is oral, should be taken in a climate myasthenia gravis that is stable, okay, an hour before each meal. So the maximum strength is before during the meal, but those symptoms translate, okay, that the client is presenting a deterioration of the condition, and you don't need to have the clients in apnea to consider the clients is in myasthenia crisis. The nurse is teaching the client how to properly use a dry powder capsule inhaler. A similar question is in English. How should the nurse instruct the client to use this type of inhaler? Shake the inhaler before putting it in the mouth. Seal the lips tightly around the mouthpiece and inhale rapidly and deeply. Rinse the mouthpiece in hot soapy water after using. Uh, breathe in the medicine slowly and breathe deeply for about 3 to 5 seconds. What do you think?
D.
B as a boy.
Okay, what is the difference of the dry powder capsule inhaler versus the meter dose inhaler?
The powder one you need to seal the piece mouth and then you inhale.
Okay, so this is the, the big difference. Okay, the meter dose inhaler is this kind of canisters that we see more frequently, I think, or at least in pharmacology, no, that contains inside a gas under pressure, and the medication is liquid. Liquid, because this liquid is a suspension, requires to shake, the liquid before using the meter dose inhaler to resuspend, to make even the liquid, because it is a suspension that can separate, can precipitate. But the medication is liquid, and when you push the canister, the gas produces a nebulization. So the liquid is going to be forced and is going to form little teeny particles that is like a cloud, is a nebulization. And then the mouth of the client need to be open. The mouth need to be open. It need to be open. Doesn't need to be closed. And then the mouth is open, and the mouthpiece of the canister is placed like 1 inch separated, okay, of the mouth, and then simultaneously you push and you have the first puff, then you inhaled, okay, but with open mouth. The dry powder generally are discs, can be different, but the most common is the Advair, which is a disc that has a mouthpiece. Inside this disc, you have capsules of the medication that rotate when you activate a lever that have here, a lever that have here. The capsules align into position with the mouthpiece, and some needles break the capsule, so the powder is released. So the patient need to seal the mouth, okay? Need to seal the mouth tightly around the mouthpiece. And there is no liquid that propels or impulse the medication out. is the own client, the one that need to suck the medication. So need to suck, okay, the medication, sealing the lips tightly around the mouthpiece. Is the big difference of the dry powder inhalers versus the metered dose inhalers. Nclex question. And the answer was this, exactly. Exactly. And one of the questions that have been in. Okay, good. So you know it. Very good. Perfect. A nurse is caring for a 14-month-old diagnosed with cystic fibrosis. The the parents state this is the first child in either family diagnosed with this disease and ask about the risk to future children. What is the best response of the nurse? 1 in 2 chance that each child will have the disease. 1 in 4 chance for each child to carry the trait. 1 in 2 chance of avoiding the trait and disease. 1 in 4 risk for each child to have the disease. What is your proposal?
B.
D as in diamond, B as in
B as in boy.
B as in boy, B as in boy. I'm
B.
sorry, B as in boy. Okay, you need to know that it is a recessive, autosomic recessive disease. You need to know that for each trait, we have 1 trait from mom and 1 trait from dad. I mean, we have 46 chromosomes, yes? 23 chromosomes with multiple traits are coming from dad, and 23 are coming from mom. Yeah.
No,
So
Professor, I'm sorry. It's D as in dog for me.
you're
Yes.
correcting. You're correcting.
Yes,
Yeah.
I
Okay.
think too
Okay.
fast. Sorry.
Okay. 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 And okay, for the people that are not so clear or heard, remember that let's suppose that the dad of this child, the male, is having um, 1 chromosome which is healthy, 1 chromosome that is sick. And the mother, the mother, no veo. the mother, the mother is also having 1 chromosome that is, healthy, 1 chromosome that is sick. They don't suffer the disease because this disease is recessive. Both chromosomes need to be read. Both chromosomes need to be sick to have the disease. When they make a child, when they make a baby, yo no veo ese punto. When they make a baby, they have the following possibilities that give this chromosome, which is okay. Mom give this chromosome that is okay. This is a possibility. The other possibility, dad give this chromosome, which is okay, but mom this chromosome, which is sick. Yeah. So I have already all the possibility of combination of this chromosome. Okay. I eliminate this chromosome. Now the other possibility, dad give this chromosome, mom give this chromosome. Yeah. So now, this is the other possibility. And the other possibility is that give this chromosome, the red. Now I finish with that chromosomes. And mom give this chromosome. Okay, those are the 4 possibilities, the 4 chances that can occur each time they make 1 baby. So what I have here, I have one individual in 4, because there are 1, 2, 3, 4. 1 in 4 that is clean, is the one that say
A healthy people
this is
because
C,
the
no?
other one,
One 1 in 4 chance of avoiding the trait and disease. O sea, it is the individual that avoided the trait and the disease. So this guy is clean, even is not carrying the trait, the disease. Yes. So C, the client that is avoiding the trait and the disease is wrong. What is wrong? We say 1 in 2 is 1 in 4. Yes, 1, 2, 3, 4. So that's why it's no. B, 1 in 4 chance for each child to carry the trait. No. To carry the trait is 3 in 4. 2 are just carrying, one is suffering the disease. Yes. So no, it is wrong. The number 1 in 2 chance for each child will have the disease. No, it's 1. Only this guy will suffer the disease. 1 in 4, no 1 in 2. So 1 in 4 risk for each child to have the disease is the correct answer. 1 in 4, okay, 1 in 4, 1 in 1, 2, 3, 4, risk, because it is a risk, it is a chance, okay, of having the disease, which is the same as 25%. 1 in 4 is the same as 25%. Yeah, it's the same. Okay, so you know this and you correct that. So tell me something. Is okay to read twice the question, and if you realize that you committed a mistake, to correct the answer, yes or not?
Yes.
Absolutely, because I am an enemy of a legend or tradition, etc. Or somebody, never change your answers. Never say never. Okay, if you don't have any idea of what you answer, follow your instinct, follow your gut, choose one and move on and stop changing. Why? Because you don't know, you don't have any idea what you are answering. But if you are sure that you committed a mistake, as you did, and then you go back and you change your answer, before passing to the next question. In English, you pass to the next question, like in the school, and you cannot go back. But before moving up, that's why I always review my answer. After I answer my questions, I go back, read the question again, and review to be 100% sure that this is the answer that I want. So I'm sorry if I disagree with the people that have been telling you, don't change your answer, don't, because it is when you don't have any idea what you are answering. When you know your stuff, as you know, you can go back and correct the mistake. I had that here. Look at this, just to avoid doing that. Okay, it's the same. The nurse is caring for a 16-year-old client who had a surgical repair of a fractured femur 14 hours ago. Femur, fracture. Okay, femur. Automatically, when they say femur, I think in one disease. This is something that we learn when we practice a lot of questions. Why? Because this bone is the one that produces this more frequently. Let's see if it is compatible. Assessing findings include tachycardia. Why? Something wrong. Increased shortness of breath. Something wrong. Something wrong where? In the femur or in the lung? In the lung. Temperature 100. It's not very specific. Feeling of anxiety. The oxygen is low. When somebody has anxiety without having bills or having a test, okay, oxygen is low possibly, and oxygen saturation of 88. What else you want? Nothing. This is a lung problem secondary to the femur fracture. The nurse immediately notified the healthcare provider, recognizing the client's at risk of which complication? Of course, fat embolism. Fat embolism. Okay, good. A classical one that you can answer straightforward. The parents of a 3-year-old asked the nurse about preventing injuries. What is one of the most effective methods caregivers can use to teach young children about injury prevention? Make sure the child understands the safety rules, explain the use of protective devices like helmets, etc. Protect the child from outside influences, set good examples themselves. What do you think?
D. D.
Okay,
Yes, and David.
okay. There is a lot of mamas out
B.
here. Okay. B. Okay. Yes, it's good. Okay, you can tell. You can tell your child. You can tell your child. Always wear the seat belt in the car, but you put the seat belt on you. Do you think that this is going to be accepted, respected, or internalized by the child? No. Remember that, guys. And this is one of the few experiences as a parent that I have. Children learn by imitation. Children learn by imitation. Okay? If you are, you know, wearing the helmet, if you are not smoking, if you are not drinking, if you are behaving, in a safe way, okay, they will imitate you. The answer to this question, I agree, is D as in David, D as in diamond. So children learned better by imitation. No, no listen. They don't learn listening. Okay, they don't learn listening. They have a lot of cerumen, a lot of earwax. They don't hear you. They see you, and they learn by imitation. This is the answer to this question. During the morning rounds, a nurse observed that a client diagnosed with heart failure has developed sudden anxiety, diaphoresis, and dyspnea. Heart failure, anxiety, diaphoresis, and dyspnea. So heart failure is the left heart failure, pulmonary edema. Okay. The other possibility could be a pulmonary embolism. Okay, let's see. The nurse also could take crackles. Oh, it suggests pulmonary edema and suspect the client is experiencing acute pulmonary edema. Okay, in pulmonary edema, you have liquid in the lungs, and then you expect to find crackles. Which nursing intervention should be performed first? Okay, what you do first with this client. Assess the client vital signs. Administer IV furosemide and morphine as per protocol. Place the clients in a sitting position with legs dangling. Contact the rapid response team. What you do first?
C.
C as in cat.
Exactly. Sit the client. This immediately relieve relieve the dyspnea. And then next put oxygen. Yes. And then part of the treatment of the pulmonary edema is morphine because alleviates the shortness of breath, but also because it's a potent vasodilator, decreases the capillary pulmonary pressure, and then the leakage of liquid stops. Okay, so and then after that, administer the furosemide. Furosemide takes a little to start working. That's why it's not the most rapid intervention. Yes, so absolutely. This is the order of that. First, you see the client, so you are good also in this. No problem with this. A triage nurse has 4 clients that arrive in the ER within 15-minute period. Which client should the triage nurse must be seen by the healthcare provider first? Which clients is more critical? An older adult client with complaints of frequent liquid brown colored stool, so has diarrhea, at risk of dehydration, but is a risk diagnosed. It's not an actual diagnosis. We can rule out this. A 2-month-old infant with a history of rolling off the bed who has bulging fontanelles and is crying. So he or she fell from bed, hmm, rolling off bed at 2 months is suspicious. No, it could be abuse, and has bulging fontanelle but is crying. It could be a trap. So bulging fontanelles are expected when children are crying. If the child is not crying and there are bulging fontanelles, then we suspect ICP, increased intracranial pressure. So let me leave here like, I doubt, okay, what to do with this because this looks like a rolling of bed, okay, could be neglect or abuse. And probably this is not important. Let's see. Teenager who got a cinch beard. Oh, while camping at the site more than 1 hour away. Okay, so the flames, okay, the fire was in the face and burns the hairs of the beard. And a middle-aged female client with intermittent pain behind the right scapula probably is having a gallstone, so this can wait. So what you choose between B and C?
C as in cat.
B as in cat,
Sí,
thinking in
because
burn of the
because of
airway.
inflation.
Okay, burn of the airway, which is the A of ABC. I agree with you. I agree with you. This is a high priority because it's A of airway. Yeah. Okay. No problem with that. It is another kind of question that is so frequent in English. Sometimes the mustache, that one that are cinched. Sometimes it's the eyebrows. Sometimes it's the nasal hair. But they are all time burning the hairs of the face to make you prioritize because if the flames, the fire was in front of your face, then you could breathe in the heat and burn your airway, producing obstruction of the airway. During the initial physical assessment on a female adolescent who is a Vietnamese immigrant, a nurse notices circular ecchymatic areas on the client's back. What is the best action for the nurse to take at this time? Ask the client for more information about the nature of the bruises. Document the finding as mark of cupping, a traditional Asian treatment. Discuss with the client and the family about the purpose of the cupping. Report the bruising to social services for follow-up. Thinking in abuse. What do you think?
B.
A.
B.
I would say A.
So you are between A and B. It is the usual. So we are assuming that it is cupping. Why? Because we are profiling that the girls is Vietnamese. We are profiling that Vietnamese do cupping. And the same way that we are profiling
But
that
you cannot assume.
all Cubans play baseball and all Venezuelans eat arepa and all Jamaicans, I don't know, like chicken, etc., etc. You know, so take care with that. So shouldn't be better to verify what we suspect that it would be a cake cupping because they don't mention here that those marks because you didn't see the cup. So if you need to choose between A and B, the assessment of A will confirm that that the marks are copying as we suspect. Okay, but better, much better is option A because B is an assumption. Remember that we cannot assume. It's better to verify. How verify? Talking to the people, you know. So it is a classical question. It is a typical question in which we need to train ourselves. We need to and to practice this kind of questions. So the next time that they make you choose between assessment to verify our assumption or to correct our assumption is a better answer than giving for certainty that our assumptions are exact, never fail. You understand? So the answer is A, guys. The best answer is A. A, B cannot compete with A. Probably you are right. Okay, I bet that 95% it is copying. But what about the 5%? Could be another thing, and you are assuming that it's copying. Okay. What other strategy could be used here? So notice that you have copying here and you have copying here. So there is no big difference between B and C, are very similar. So it should make you suspect that if two options are so similar, that again shouldn't be the answer. And okay, before reporting this, considering that we don't know really what is the nature of those bruises, and we suspect it could be a traditional Asian medicine that is not considered abuse. Okay, still the assessment, as the client for more information about the nature of the bruises, is going to win all the other options. Please, I think that this question is important to read 2 or 3 times to be sure that we learned that in this case assessment trumps the other options, even if we are almost sure that it is copying. But unless we see the cup, we remove the cup and we see a bruise that was not before the cupping, we cannot assure that those bruises are copying. Santo Tomás, ver para creer. We need to be very objective, okay? Very good. A client diagnosed with gouty arthritis is admitted with severe pain and inflammation in the right foot. Podagra. Remember this name? This is the name of the inflammation in the base of the great toe that is characteristic of the acute arthritis or crisis of gout. Which intervention should be included when the nurse develops a plan of care? High protein diet, administration of prescribed allopurinol, hot compresses to affected joints, fluid intakes of at least 3,000 milliliters per day.
Letter D.
Everybody agrees?
Fluid.
Nobody wants to give allopurinol to this client?
No.
Nobody? Sure.
Nope.
Okay, so you're
I choose B, but I don't know.
no, heat will produce more vasodilation. If you have swelling,
No, 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 no,
remember
no.
that. If you
Why
have,
not?
okay,
Why not allopurinol, professor?
allopurinol has demonstrated by evidence. Okay, so Pete, somebody needed, okay, to discuss that. Allopurinol has demonstrated by evidence that makes the arthritis worse. The logic say, okay, the arthritis, the podagra is consequence of the too much uric acid. So if I give a medication that lowers uric acid, the arthritis should improve. Okay, what happened when they started giving allopurinol to clients with podagra, they got worse. This is called evidence-based practice. It sound logic, but when they was taken to the practice, the clients didn't improve. By the contrary, they deteriorated. The inflammation become, more intense. So they concluded, and this is the protocol, that when you have this crisis, when you have the joint red, swollen, painful, warm, yes, you should not use the allopurinol. You should use colchicine. Colchicine. Colchicine is very effective to reduce in hours, in few hours, the inflammation of the podagra. After the inflammation subsides, disappears, is when they can start the allopurinol to decrease the amount of uric acid in the body, and probably the patient will continue taking the allopurinol all life long to prevent future crisis of gouty arthritis. A part of the diet and a part of the increase intake of fluids, because the other problem of uric acid is that uric acid precipitates in the kidneys, producing tubular damage, renal failure, multiple kidney stones, and then it's much, much, much serious. The kidney, the renal damage of the uric acid, than the pain of the acute gouty arthritis. So remember that for the acute gouty arthritis, no allopurinol, colchicine. Colchicine in some clients produces diarrhea and is not tolerated. In that case, they give NSAIDs. For example, indomethacin, Indosit is frequently used, but can be ibuprofen, Advil, etc., etc. Okay, but the drug of choice for the acute arthritis is colchicine, not the allopurinol, because it's what evidence has demonstrated. And this is something that happens with a lot of other circumstances in which the logic say, oh, this should be good. Oh, okay, no, the outcomes of practicing, of doing research, evaluating what you are doing demonstrate the contrary. So we need to change, okay? Very good. So that's why no allopurinol in the acute, okay, once this arthritis is controlled, generally in hours with the colchicine, then the allopurinol will be incorporated to lower the uric acid. But if you give the allopurinol while the joint is swollen, becomes much more swollen, much more difficult to improve. In relation with the heat, remember the heat produces vasodilation. The vasodilation increases the leak of fluid and more inflammation. So when you have this kind of inflammation, like the gouty arthritis or trauma, uh, a, a sprain of the ankle, etc., you put cold to produce vasoconstriction, and to return the liquid to the circulation. Okay? The exception of this is rheumatoid arthritis. The rheumatoid arthritis, which is other disease, okay? The rheumatoid arthritis, okay? In which there is a symptom that is not the pain, it's not inflammation, it's the stiffness, it's the rigidity, okay? Or a stiffness, morning stiffness, okay? That the client experiences that improve with heat. But it is different. It's not for the inflammation, it's for the rigidity and the stiffness. Don't confuse rheumatoid arthritis, which is an autoimmune disease that affects all the joints of the body. With gout, which is a metabolic condition, not autoimmune, that is people that have too much uric acid, and the uric acid can precipitate in the joint, especially the base of the great toe, producing a very painful arthritis. Acute in hours. It develops in hours. It's very painful. But worse than that is the kidney, the renal damage. That's why the answer of this is DS in diamond. So learn that from uric acid. Also remember the diet, which basically what the clients must avoid is organ meats, but few people consume organ meats. That's why it's not frequent in Nclex. Liver, kidneys, etc. But it's not usual in the American diet. But the other stuff that is very rich in purines and contraindicated in gout are shellfish, shrimps, lobster, crabs, clams, oyster, etc., etc. Scallops. Always there is a scallops in the dish. Scallops. Some of us don't know the scallops. Okay, it is a shellfish. Okay, a scallops. Okay, and yes, there is one. And the other is the fluid. A brief review of uric acid and related diseases. Sometimes the uric acid precipitates in the skin, producing like subcutaneous tumors or accumulation of uric acid, and those are called tuffus. Perdón, tuffus, okay? Plural to find, okay? And they can show you an ear, a picture in ankle ear with little, looks like pimples, like pus, but it's not that. Is uric acid, and this is toughest. Okay. This is what has been tested more frequently about gout in Nclex. Study gout because it's frequent in your Nclex. The charge nurse is reviewing the protocol of care for clients with cervical radioactive implant with the new nurse, which statement tells the charge nurse that the nurse requires more teaching. Visitors cannot stay more than 30 minutes in the client's room. I think this is true. A long tongue, you know what is that, no? This is a tongue, okay? Should be kept in the room in case of implant dislodgement. Why? Because you cannot hold the implant with your fingers, not even wearing gloves. Gloves is not going to stop the radiation. Distance, so being away, that's why the long tongues, and lead, the metal, the heavy metal, okay, is the only thing that can stop the radiation. The client has to wear a dosimeter at all times. Dosimeter is like a badge that has inside a substance sensible to the gamma radiation, and it's like counting the accumulated dose of gamma rays that the batch is receiving. So wearing this allows the expert to know if the person that is wearing the badge, how much dose of gamma rays has received. And visitor had to keep a distance of 6 feet from the client's bed. What is the answer?
Sí.
Dear dog.
Sí.
Dosimeter for
The
the
answer
nurse.
is C. The one that need to be measuring
The nurse.
how much radiation has been receiving while taking care of clients with cancer that sadly must receive high doses of radiation. So the client, the patient with cancer must receive the radiation. The dose of radiation is not measured this way in the client. The problem is that the implants that emit radiation, we nurses, doctors, CNAs, housekeepers, whoever enters the room of those clients is receiving certain amount of radiation, of gamma radiation. And there is a limit, it is a dose, an amount of radiation that is safe. If you reach or approximate to this maximum dose, this is detected by this device, the dosimeter, and then inform to the expert, this nurse, this doctor, this CNA, this housekeeper cannot Vallin cannot be involved in the treatment or management or care of client with implant for a while. That's the rationale for nurses, doctors, CNAs, etc., wearing this badge when entering and approximating clients with radioactive implant, which is the case that is presented here. So it's not the client. The client doesn't need to wear that. It's the nurse, it's everybody. Yes. Visitors should be kept at 6 feet of distance of the client because, as I said before, what can block or reduce the radiation is one, the distance. The farther you are from the client, the lower the amount of radiation that you receive. And second, lead. Lead is a metal that can block the gamma ray. That's why nurses that need to be entering frequently there should be wearing a lead apron, a lead apron, lead apron, okay, delantal, lead apron, okay. Okay. So it's clear. If you disagree or if you don't understand, speak up. Speak up. Remember that this is a good to discuss. It's good to discuss. Okay. The nurse performs a heel stick for a blood glucose check on an 1 hour old full-term newborn who weigh 9 pounds. 9 pounds, okay. At birth with a normal suction reflex. The serum glucose reading is 45 milligrams per deciliter. What action should the nurse take? Ask another nurse to perform a second blood glucose check. Repeat the test in 2 hours. Check the pulse oximetry reading. Start an IV infusion of 5% dextrose. What do you think of these 4 options? This glucose is normal or abnormal?
It's in the limit, Professor.
Well, it's
Uh,
normal. It's normal.
Normal.
It's normal. It's in the limit of normal, but it's normal. So what is the answer?
Sí. So it's C as in cat.
Continue. No. Okay.
Ah, re- bueno,
What had to do? What had to do the oxygenation with the glucose? Nothing. So
nothing.
what you if something normal, continue monitoring the glucose. Okay.
So
Okay.
repeating 2 hours.
Sí.
Repeat in 2 hours. Okay. The baby is okay. Is suctioning is okay. There is no the option of feeding the client. That is what you was looking. So what if it's normal? What you do with normal value? Continue the monitorization. Repeat in 2 hours the glucose. Continue the monitorization. Do you need to monitorize glucose in newborn? Yes. Why? Because newborns normally are born with low glucose. compare with the later life, no? So 45 to 70, 75 is the normal. So 45 is normal. So continue feeding the baby, okay? Because the baby need to be, they already checked the suction, okay? So, but they are not mentioning here if you feed the client. It is assumed that is fed because, okay, babies when they are born are going to be early fed. They already check the suction, so it's going to be fed. But the glucose is normal. Okay, what you do, you repeat, continue the monitorization. Oximetry is not needed. You don't need to administer IV dextrose because it is not done unless the hypoglycemia is too severe or the baby is having seizures, cannot feed, etc., etc. You know, if the baby is having a blood glucose, which is so all babies are going to have early feeding to prevent hypoglycemia. If the baby having hypoglycemia, but the baby can swallow, the baby is going to be fed. This is the treatment of the hypoglycemia. If the baby cannot swallow and there is an order of a gavage, gavage is a nasogastric tube. Okay, somebody had this question recently, and this person who had this question didn't know what gavage was. Gavage is a nasogastric tube, very fine, very thin, that is introduced in newborns preemies that cannot swallow. Okay, so are going to be fed with gavage. Okay, if the baby having seizures or the blood glucose is below 30, then probably the doctor will order administering IV dextrose, but it's much more lower and or the baby is unable to eat. Okay, but this is not the question about. This is a question about the baby have 45. The baby is okay. What you do? There is no discussion here about feeding. You assume that it's being fed. Okay, the answer is continue monitorization of the glucose. You don't need to ask another nurse to do the same that you did because it's okay. But you need to ask, I'm not sure, I just did an AccuCheck, I'm not sure what is. Okay, maybe if you don't correlate the value with the clinical situation, you can change the AccuCheck machine. It makes sense, but not asking another nurse to do that. So you rule out A, okay? Oxygen has nothing to do with this case. Why am I using IV dextrose if this child have a normal suction reflex, can eat? So the best answer is continue monitorization. Okay. Sometimes we complicate the question without need. Do you notice that? Okay. All we have this tendency, but we learn how we learn to avoid those mistakes. Practicing questions. Which absent milestone should concern the nurse in a 3-year-old child? That is 3 years. Cannot draw a square. Guys, to draw a square is very difficult. Angles are very difficult to draw. Triangles and squares after 4 or 5. What they can do is circle. No problem with a circle. They can imitate a circle, but geometric figures with angles, forget it. 3 years is too. So no problem. I don't care that they cannot do a square because it's too difficult for them. Cannot hop. You know what is hop? Jumping, no? In 1 foot. It sounds a little, a little demanding. Generally, they can start hopping in 1 foot. They can stand. At 3 years, they can stand. Just stand in 1 foot. Okay, they can stand in 1 foot. But hopping, jumping in 1 foot, like playing I don't know how to call that. I always forget how to call that in English. Okay, it is too much for 3 years. So I don't concerned about that. Cannot eat with a spoon. Ooh, ooh, ooh.
I think it's that one. It's
A
concerned.
spoon, yes, is very basic. okay, is very basic because my grandson that is now visiting, okay, that is just had the 1 year yesterday, took my spoon when I was drinking ice cream, took my spoon and started drinking my ice cream. So, and cannot catch a ball. Okay, I am almost 70 and I cannot catch a ball. I'm very bad playing baseball, so it's okay. So the answer is C. And those questions, can be answered a lot with common sense. And any one of you that have the, the, the luck of having children, is going to be easier. To the blessing. A 2 years old child is brought to the pediatrician office by the parents who report that the child has been having diarrhea for 2 days. What nutritional information should the nurse provide to the parents? Give the child only clear liquids and gelatin for 24 hours. Continue a regular diet and add electrolyte replacement drinks. Regular diet. So eat the regular, as the same that you have been eating always. Give the child bananas, apple, rice, and toast. Okay. So the bread diet, no? The bread diet. Banana, rice, apples, and toast. Keep the child fasting, give them nothing to eat, and then return the next day. What is the correct answer?
C.
B.
C.
No, the correct answer is B.
B.
In the past, was this. Rule out the new policies, or the updated policy, not the new, because they are not new. The updated policy say no, this is a diet that doesn't provide enough nutrients and is not doesn't have any advantage in case of diarrhea. The recommendation in diarrhea is to allow the child to eat, offer this regular diet, allow the child to eat at demand, but force or encourage the consume of electrolyte solutions, oral electrolyte solutions like Pedialyte, etc., uh, to replace the loss of fluids. So this is the answer. I'm pretty sure. Okay, this is the answer. No more blood dye. Okay. Nurse received 4 phone calls from pregnant women in their last trimester of pregnancy. How many songs are 4? Okay, 4 a term or last trimester. Okay, ladies, which call should be answered first? Okay, client can't sleep supine because turns her breath. Client with frequent heartburn. Client who can't remove wedding ring. Client with frequent non-painful uterine contraction. What do you think?
C. C.
C.
Están
Sí.
cortando rabia oreja. Very good. See, this is concerning. Edema in the legs, edema in the ankle, pedal edema are expected at the end of the pregnancy. But edema in the hands, edema in the face is not expected and suggests severe edema that could be associated with preeclampsia. Having heartburn is part of the pregnancy. Being unable to tolerate the supine position because the size of the uterus and the compression of the diaphragm is expected. That's why I need to sleep in lateral position. And having non-painful uterine contractions, such as Braxton Hicks contraction, which is normal at the end of the pregnancy. C is the answer. It's a classical question. Don't fail this question. The nurse has given discharge instruction to a client who underwent abdominal surgery. Which of the following statements indicate that the client correctly understands how to manage their pain at home? Pain management, abdominal surgery. Okay. My discomfort should be relieved within 10 minutes of taking my pain pill. What do you think? Yes or not?
No.
No.
It could be
Oral medication pills don't work so fast. cannot work so fast. So this is not realistic. You need to explain that it is not realistic. You cannot expect such a fast relief of pain. It's going to be relief, but not so fast. So it's not realistic. I agree. Don't mark this. Before I take an herbal supplement for pain, I should check with my provider. Of course, the answer
Yes.
is yes. Listening to my favorite music might help control my pain. But you answer? Yes. It is a
Yes. As a distraction.
non-pharmacological intervention for pain that help, doesn't mean that replaces, is helping the pain medication to control. My goal for pain relief should be 0 on 10 on pain scale.
No.
No,
Unrealistic, Professor.
non-realistic,
Unrealistic.
non-realistic. It is non-realistic. No, 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 no,
Mhm.
no, no. If you decrease that to 3, 2, 1 is enough. A warm shower before bed may alleviate my pain and help me sleep. Yes or not?
Yes.
Yes.
Yes, yes. Making pressure over the surgical wound will ease my pain when I cough. Yes or not?
Yes.
Yes.
Yes. How we call
Yes.
this? Splinting.
Splinting.
Yes? Splinting. Okay.
Explaining can evitate evisceration as well.
And also avoid dehiscence and evisceration.
Mhm.
Okay. Let's make one page more. The nurse is providing care to an older adult client diagnosed with bilateral pneumonia. Ay, my God, pobrecito. Which intervention should the nurse implement to best promote the client's comfort? You need to be very careful in English with this word. Now it's not about life or death or death situation. It's not priority, it's comfort. So they make this question a lot. Like, for example, what you do in a client with hypothyroidism for comfort, and then keep the room warm or give a blanket. For a client with meningitis, what you do for comfort, you keep the light dim, keep the room dark because the photophobia. So there are questions about comfort. The client has bilateral pneumonia, and the issue is comfort. So what do you think is the best that you can do for this client, okay,
D.
for comfort? You say
D.
what? D as
D
in,
as in David.
D as
As
in
in David.
David. Of course, that's
Yeah.
it. You are you are clear, okay? So if you are short or breath in, you are making an assessment of, you understand that if you are making questions or interaction or too difficult, too prolonged, etc., to the clients, making question that can be postponed is something that is not appropriate. And for comfort, you should keep conversation for it. Fluid intake is important, is a life or death situation. Encouraging visits is not good because the client precisely is the opposite of D. And monitor vital signs frequently is life or death situation. It is not for comfort. Okay, very good. A diabetic client has been diagnosed with gastroparesis. Okay, it is a tricky question because it is a term that not everybody manages. Nevertheless, you should learn that paresis is a weakness because you can have this word hemi or hemi paresis. The same that you can have hemi or hemiplegia. You know that after a stroke, you can have half your body or weak or paralyzed. If it is weak, it's hemiparesis. It is paralyzed, is hemiplegia. So you need to know this terminology. Okay, gastro is systemic. Paresis is a weak stomach. What is the role of the stomach? The role of the stomach is to receive the food that you eat, keep the food for a while inside, churn the food with the juices that are produced in the stomach, but then the stomach should contract and empty the food in the intestine to be digested. Sometimes, do you know that the stomach has muscle, smooth involuntary muscle, controlled by the vagus nerve, the parasympathetic nervous system, that is the muscle that is stimulated by the vagus nerve to contract and move the food to the duodenum. Okay, sometimes it usually occurs between 1 to 3 hours after eating this gastric emptying. Mm? But sometimes there is generally disease of the vagus nerve, disease of the parasympathetic nervous system, autonomic problems. And for that reason, the stomach becomes lazy and they don't empty. So the patient ate 5, 6 hours ago and still have the food in the stomach. This is called gastroparesis. Okay, so that's it. It is very frequent in diabetic clients. If the client were having a nasogastric tube, then you would be finding an increased residual when you check for residual. Okay, a diabetic client has been diagnosed with gastroparesis with medication not expected to be prescribed, omeprazole, metoclopramide, metronidazole, ranitidine. What is the answer?
B as in boy.
Metoclopramide is a prokinetic that is frequently used to move, to empty the stomach. Metoclopramide also can be used for nausea in any of us, because if we have nausea and we empty the stomach, we promote the gastric empty, probably because we are going to experience relief of our nausea. Remember that metoclopramide can be tested also inhibit the dopamine receptors, the same as the antipsychotic, okay, and can produce extrapyramidal syndromes. Acute dystonia, Parkinsonism, akathisia, oculogyric crisis, tardive dyskinesia, blah, 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 blah. Okay, this is a brief pharmacological review of metoclopramide. Which of the following clients have a formal indication for screening of hepatitis C carrier status? You need to know that hepatitis C has a problem that when somebody gets the hepatitis C virus, let's see, I don't know exactly, but 85% of the clients will cure and eliminate the virus. But then, 15, 20% of the clients cannot cure, cannot clear, cannot eliminate the virus, and the virus stays living in the liver lifelong. Those are carriers of the viral hepatitis C. It is an issue because those clients can have damaged their livers with the time because the virus, they can develop cirrhosis and can develop liver cancer, primary liver cancer, but also they can be contagious. They can pass this virus to other people, okay? And this is a hepatitis C carrier status. ¿Cómo se llama? The CDC, the Center for Disease Control, recommends that all people older than 50 should be screened systematically for hepatitis C, okay? Because it's more frequent in this generation, in the older than 50, for several reasons, okay? For several reasons. And it is true. This is ¿cómo se llama? A fact. It's a recommendation of screening of or early detection before they develop cirrhosis in older than 50. The reason for which older than 50, um, ¿cómo se llama? Require this screening is because this generation, that is the generation called the baby boomers, okay, was a generation that frequently used IV drugs. IV drugs. Okay, IV drugs was very common in this generation, the hippie generation. And the other reason for which they are at increased risk of this is because until 1980 something, 86, etc. We didn't know that this virus existed. So those clients usually receive transfusion, blood transfusion. This generation people receive blood transfusion without being screened, being ruled out the virus in the transfusion. So there are some member of this generation that receive transfusion with the virus because at that time this screening was not done, okay, in the transfusion. And was more or less in this time. I remember that this virus in my times when I was a student was called non-A, non-B virus because we knew A and we knew B. But sometimes people develop a hepatitis. The test for A was negative. The test for B was negative. So we call that non-A, non-B hepatitis. And we noticed that the majority of them have a common history, recent history is transfusion. Later, around this time in 86 and beyond, they discovered the virus. And then it was not until the 90s that they started screening systematically in all the transfused blood for the virus. Summarizing, many people before that time received transfusion with the virus. Okay. Okay, once I give the explanations, will facilitate you answering this question. Okay, who can be a carrier of hepatitis C? A client who ate contaminated shellfish, yes or not?
Yes.
No, this is for hepatitis A only.
Oh.
Okay, so remember that shellfish is an etiological factor for hepatitis A only. Very important, okay, because it's tested for hepatitis A. So no. A client who received blood transfusion before the 92, yes. I just explained that.
Yes.
A
Sí.
client in long-term hemodialysis, yes,
Yes.
for the
Yes,
same
sir.
reasons. Hemodialysis is an environment where there is a lot of blood moving in, blood moving out, and this is a lot. There is very high risk for this kind of bloodborne pathogens in hemodialysis unit. A client who injected IV drugs only once, many years ago, yes, only once can be enough. A child born from a woman hepatitis C positive, yes,
Yes.
it can be passed through the placenta. And what about this? An extensively tattooed client.
Yes.
The answer is no.
No.
Hepatitis
But,
A.
okay, I didn't know that. Okay, I'm an old person and I'm prejudiced. Okay, my generation is prejudiced with the
But
tattoos.
that is not exist long time ago.
Okay, but I had to go and make a review.
But you can
About
get it through a tattoo, don't you?
mute your microphone. And what we found that the research, the evidence says that here in America, the tattoos parlors are supervised and authorized and supervised by the Department of Health and are very safe places because if they don't follow rules of sterility, they don't have the license and they are, they are not allowed to practice. So in America, it's very rare that tattoos transmit, okay, bloodborne pathogens. So the answer is no. Are we good? Do you understand what I'm saying?
Yeah,
Yes.
I thought you had a risk for from tattoos as well, but no, I'm wrong.
It is not. It is not. Because here, take care. If you go to have tattoo in in Thailand, okay, take care. I cannot guarantee that, but at least in America, because the control Department of Health. How the nurse explores the fifth cranial nerve. Okay, fifth cranial nerve is the trigeminal nerve. Cell that apply. Make the client close the eyes and smile. Yes or not?
No, it's the 7.
Correct. This is the seventh. This is the facial. Okay? This is the way that NCLEX asks about assessment of cranial nerve, how you explore those nerves. Is remember that NCLEX will give you the license to do assessment, which is a privilege of the RN. So you need to have knowledge of assessment. Cranial nerves are tested frequently in NCLEX, simply like this. Well, how you explore this nerve or that nerve. Make the client close the eyes and then touch each side of the face with a cotton. For what? To see is feeling the same. Yes, because
Yes.
it's a sensorial nerve. You are exploring there the sensation of touch. Very well. Ask the client to clench the jaw while palpating the muscles masseters. Muscle masseters are those muscles we have at each side of the angle of the jaw that we use to chew. Yes or not?
Yes.
Yes, it's the
Yes.
portion motor of the
This
fifth
is the
one.
motor portion of
Mm-hmm.
the fifth cranial nerve. Very good. Obtaining the blinking reflex blowing on each eye.
It's
What
related with the corneal
this is
reflex.
the cornea. This is the corneal reflex. And
Yes.
which nerve gives the sensation of the cornea?
Trigeminal.
The trigeminal nerve.
Right.
So when you blow the eye, the nerve feels that you are blowing the eyes, and instinctively you close the eyelids. This is the blinking or corneal reflex. Yes, this is exploring the fifth cranial nerve. Asking the client to move the eyeballs in all directions.
No.
This is the third, the fourth, and the sixth cranial nerve. Oculomotor, the trochlear, and the
No.
abducens cranial nerve. Very good. This is a no. A no. Okay, remember that you need to review your cranial nerve because I can assure you that are frequently tested in your NCLEX. The nurse is assessing a client in her third trimester of pregnancy, okay, the last trimester. The recent ultrasound suggests the baby is small for the gestational age. Okay, there's a problem there. The baby is not growing as fast as expected. However, an earlier ultrasound indicated normal growth. So this is a deceleration of the fetal growth in the last trimester. The nurse understand that the most likely problem causing this is maternal hypertension, chromosomal abnormalities, sexually transmitted infection, exposure to teratogens.
A.
What gives the food and the oxygen to the baby to grow? The placenta. The placenta is aging as the pregnancy advances. And of course, each time is providing less nutrients and oxygen. But this aging accelerates, speed up in case of hypertension, in case of diabetes, in case of use of drugs, especially cocaine and amphetamines, etc. So yes, maternal hypertension is one of the causes of chronic placental insufficiency. Chromosomal abnormalities, teratogens will be affecting the pregnancy at the beginning, since the beginning. And what they said, at the beginning, no problem. The problem is at the end. So it is an accelerated aging of the placenta as consequence of hypertension. The answer is A. Okay, the last guy. A client with severe dehydration is receiving fluid through a peripheral IV. The client is confused and pulls out the IV catheter. Very common situation in nursing. What is the nurse priority in this case? Obtain an AMD order for arm restraint. So a restraint to avoid the clients, a wrist restraints is what they call this restraint. Insert another IV catheter and reestablish fluids. Explain the client the importance of not pulling the IV. Medicate the client with the PRN order anxiolytic medication.
B, as in boy.
Of course, because they are asking what is the priority. The priority is the patient is dehydrated and they has ordered IV fluid, but the IV fluid are not passing. Why? Because the clients removed the IV catheter. The priority is restarting the IV administration of fluids, and later to see how we deal, okay, with the behavior of the client. Okay, guys, this is what I have for you today. Any question?
No, professor, thank
Thank you.
you.
Okay.
Thank you very much.
Well, I see that some of you are ready. Okay, so good luck. Okay,
Professor,
see you next. Dígame.
I want to
Yes,
say something.
yes, go ahead.
My name is Andrina Zambrano. I took the Nclex last Saturday and I passed. Thank God
Oh,
we 85 questions.
congratulations.
Thank you. So I want to say thank you so much to you because when I was in several questions, I was remind you.
Oh, thank you.
One of the questions took my really attention, and the question was about sickle cell anemia.
Okay.
But the question said that one children's with 5 years old, he born with sickle cell disease.
Mhm.
So they are trying different treatments and nothing happened to him. He cannot improve with anything. So what you have to do to avoid crisis in that child? So I remember the two more important options. And one of them was about if you need to touch the spleen of the child to see if the child have the spleen large or decrease. And another one that was that I select was that you need to do a splenomegaly to the child to avoid crisis. So I remember
Splenectomy, removing the spleen, yes.
correct. So I
Splenectomy.
select that because I was remember when you was explaining about the thalassemia disease. The difference is about just the color, right? American people and the white people. But I didn't remember about the splenomegaly sickle cell disease, but I remember that for thalassemia disease. And I remember that you say that they
It's
are
an
the
option. It's
same.
an option.
And I said, you know what? This is the option. I'm
It's
going
an
to do
option,
this
yes. It's an
because
option.
it's this one.
If there is hypersplenism and then they do a splenectomy, yes, it's an option.
Yeah.
Okay,
So
nice.
my recommendation for the rest of the people is that my exam, for example, if we're going to talk about 100% of my exam, more of the 70% was just new English generation questions. So they are putting a lot of new generation questions.
Did you find too difficult the new generation questions?
No, because since I start practice new English, the new generation questions, I was happy because I think they give to you more information for you can know what they are talking about. Of
Exactly.
course,
So
they give to you things to try to confuse you, but if you know what they are talking about, for sure you're going to
correct.
know
So
what
it's
is
the
the
same
answer.
content. You have
Correct.
solid content you can deal. And so the information that I've been receiving from the people that recently have been testing, that those questions are not so difficult because they give you all the information. The only problem, they are time consuming because you are reading and reading and reading, need to read again, and need to go back again. So it's time consuming, but that the
Professor,
questions,
I did a test in 4 hours and a half.
okay, okay.
4 hours and a half because you have to read so careful
Yeah,
and
exactly.
read 2 times for you cannot
Yes.
lose any important
Detail.
information that can change, you know,
Mhm.
UDC.
It's a good
That
advice. It's a good advice. Take your time. Don't procrastinate, but take your time because you know those are fast testers could commit mistake in this kind of questions if you don't
and
read carefully.
you need to have this content, professor, because they ask me for everything,
Absolutely, absolutely.
everything. That
Content is the clue for the
correct,
test. And
correct.
they say what the content is because they have a test plan, an Nclex test plan that you can read. And really, guys, okay, sometimes the content's a little more concentrated, more summarized than the content that we give you in class, because in class we need to cover all the book, hundreds and thousands of pages. But the content of Nclex is in Nclex test plan and is the classical content. Please master your content, and you see that you will pass your Nclex. Very good advice. Very
Thank you,
good advice.
professor. You are a master.
Thank you thank you for your opinion. I don't consider myself master,
No,
but
no, you are, you are.
thank you for your opinion. Okay, congratulations and be successful in your career. And
Profe,
don't stop here. Continue studying later after you acquire some experience practicing. Continue. Go ahead.
Thank you.
Don't stay just in that. Good news. Good news. Good news. And the future of most of you
profesor,
guys. Yes, sir. Yes, sir.
igual, gracias. Pasé el ENCLE también, gracias a usted.
Oh, another one. Good. I'm so
Y lo
happy for
llamé
you.
para darle las gracias porque lo pasé prácticamente gracias a usted escuchando su clase.
Oh, and if I'm of help, I'm very happy of being helped. This is the best that I can do for you. Okay. Thank you very much
Muchísimas
for
gracias, profe.
no, thank you for sharing, and thank you for giving this good news and elevating my moral, elevating my self-esteem. Thank you very much. I need it.
Ay,
I
que
need it.
eres el mejor y es indiscutible. Eso no se
Okay.
discute.
Thank you.
He
That's
is,
true,
for sure.
Professor. You are the
I'm
best.
not, but I'm so happy. Each time one of you young people, open this door, and I know that life is going to be much better for all of you, because now with this license, okay, you can do so much, and everybody is going to improve a lot. Even your children are going to benefit from this, because now they are going to have a better life and better opportunities than you. And you demonstrate that you are heroes, because I know how difficult it has been for all of you to do this career. It's very easy for somebody, that is young without children, going to or going to, qué sé yo, to Princeton or any other university. And then after graduating, taking the same test that you were taking, because you are taking the same test that are taken for those graduated from, very well established universities, and they're, they're not having children and working, etc. So you are heroes also. So I admire all of you, and I'm very happy of being some help. Congratulations, guys. I'm very happy. I feel so well with your words today. Thank you very much for sharing.
Thank you.
Okay,
Oh,
guys,
thank
enjoy
you.
your success, and the people that are going, also be sure that if you master your content, you can pass. And see you next class.
Yes.
Okay, see you next class. Bye-bye.
Good night. Thank you.
Bye.